speaker is Dr. Anjana Krishnan, who will speak on entering the world of phaco. Dr. Anjana is a skilled phaco and glaucoma surgeon. Her session will focus on how young surgeons can take their first confident steps into phaco. Over to you,
Good
ma'am.
evening. At the outset, let me thank Dr. Nilofer, Dr. Jyoti, and iVision team KSOS for giving me this opportunity. As you enter the world of phaco, I think you should all be familiar with Dr. Charles Kellman, who is considered the father of phacoemulsification. He was also a musician, an entertainer, and whatnot. So the basics of phaco, I think all of you should be well read when you are starting your phaco, the fluid dynamics and all, the position, foot pedal, phaco tips available, everything should be well read and managed. Then the advantages of phaco is that we are shifting to phaco mainly because it reduces healing time and the postoperative astigmatism is less and the AC is more well maintained. So it has its own advantages and risks also. So patient selection has already been elaborated by Dr. Nilofer and Dr. Shobha. So an ideal patient should be around 60 to 75. It's a rough estimate. The only thing which I like to highlight is if it's an older patient, say 80 plus or so, if you assess it as an NS2 cataract on table, it might be NS3. And the sonules may not be as strong as you assessed on a slit lamp. So it avoids such extremes of age. And NS2 to 3 well dilated pupils, not deep set, not shallow AC, no pseudo exfoliation or other additional risk factors which may spoil your confidence. And the general considerations about other things like anesthesia, initially it's better to start with a peribulbar block. If you are comfortable with subtenance, you can start it. Topical you can reserve for later. The position, as already mentioned, temporal has its own advantages, but if you are a good superior SICS surgeon, you can start phaco from the superior position also. The main thing is you should be able to convert with confidence. And as already Dr. Shobha has mentioned, a scleral tunnel 1 to 2 millimeter behind the limbus in the initial stages will help rather than a clear corneal incision. The different methods of phacoemulsification are divide and conquer, stop and chop, and phaco chop. And divide and conquer is the basic technique. That is the best method to start your surgery with. In this, we are sculpting a groove into the nucleus and cracking it into pieces. The ideal position of the phaco probe and the second instrument is 2 clock hours away from each other. It will allow you the ease of manipulation. And the phaco power settings is usually while you are sculpting, the main aim is you have to sculpt and eat the nucleus. So the phaco power is depending upon the density of the nucleus. So it's around 20 to 60%. If NS2 to 3, you can choose according to the density of the nucleus. And the fluidics is just to maintain the anterior chamber. So you need not have a good vacuum of around 100 range, and flow rate of around 20 will help. And sculpting of the nucleus is, I'm not going into the general steps while you are converting, you have already seen that. So once you are sculpting, start from the subincisional area, close to the subincisional area as possible, and this will allow you to get a longer trench. And once you are, as already mentioned, the central part is 4 millimeter, it's deeper, so you have to go accordingly, like the center should be, you can go a little bit deeper. Then once you start seeing the red glow, you can rotate the nucleus and go for the cross trench. When after apart from the red glow, the striations of the nucleus will also help you to make out that whether you have reached adequate depth. If the striations are still seen, that means there is still matter and you can go a little more deeper. And if you feel that any of the trenches is not deep enough, you can always do a little bit more trenching in that position. For denser nucleus, you will need a wider groove. Usually one width of the phaco probe, one phaco width will be good in softer ones, but if it's a harder nucleus, 1.5 width of the phaco tip will be better. So groove through the sides, edges of the first trench, so that the overall groove will be broader. And it will allow easy cracking of the nucleus in harder ones. The cracking, as already mentioned, you have to place the instrument deep inside the groove, then only you will get a good complete crack. If it is placed shallow, the posterior plate may not separate, and it will cause you further trouble during the next step. So this is the cracking. You have to place both the instruments side by side and just pull them apart, so that and make sure that the pieces are fully separated when you do it. Rotate and do it on all the 4 cracks, and you get 4 separate pieces. While doing the cordon removal, the phaco power settings has to be changed. Here we have to have more holding power and more of followability. So the vacuum and the flow rate should be a bit more on the higher side, around 300 to 500 depending on the case and the phaco machine and all. And the phaco power can almost be the same depending upon the density. The technique is you can shift the position of the phaco probe a little bit laterally so that you can get more of a hold of the pieces, bring the pieces out of the capsular bag, and phaco aspirate from the iris plane. So you can make out, bringing up into the iris plane and then slowly aspirate it and help take the second instrument to make it into smaller pieces. Once you are done with the quadrant removal, then you have to do the irrigation and aspiration. The principle here is to engage the cortex and then strip it towards the center, and from the center aspirate it. And go on in either a clockwise or anti-clockwise manner, whichever you are comfortable. Once the cortex aspiration is complete, then you have to put the intraocular lens. Ideally fill the intraocular bag with viscoelastic. I do under saline, but it's better to go with a viscoelastic filled eye, and slowly and in a controlled manner insert the intraocular lens, and with the second instrument rotate it into place. Once you are good with your cordon removal and divide and conquer technique, then you can step ahead and go into the stop and chop technique, in which you make only the initial groove and then separate it into 2 pieces. Then you can chop each of these pieces into multiple pieces, and then do as the cordon removal. Make sure at every point that you separate the pieces completely, otherwise you will end up having trouble while removing them. And once you are expert in that also, then you can try the phaco chop, in which you insert the probe into the center of the nucleus, and with a second instrument you just do the chopping and separate the pieces. Rest of the surgery is the same. Once you become good at each step, you can slowly learn the next step. So the key points to consider are: the main priority should be the patient, his vision and his general health, his comfort. You should be aware of that at every step, and whenever you are in a doubt, ask for help and learn one step at a time. Practice it, become good at it, and then go for the next one. Learn from your mistakes and others' mistakes. You can watch a lot of videos and focus on improvement, and always be ready to correct and learn. Thank you.
Thank you, Dr. Anjana, for that excellent talk.